I'd like to say good afternoon to everyone. Thank you for dialing in and taking the time to join us here today at Medicolegal Partners for our medical legal seminar on complex injuries. We are holding it today and it's being held by myself, Ash Vasireddy, and my colleague, Dr. Chris Jenner. Say hi, Chris.
Hello, everybody.
Hopefully you'll find this session today really informative, very useful. There will be an opportunity for Q&A sessions at the end. So if you do have any questions, please do type them ahead in the chat box and we'll address them towards the end of both of our talks. So I'll begin first. I'll just start sharing my screen. Okay, so for my talk today, the main thing that I'll do is address the medical legal aspects of complex trauma. So as I said, my name's Ash Vasireddy. So what do I do, who am I, etc. So that's me. So I work as a consultant orthopedic trauma surgeon. I'm a full-time trauma surgeon, so I don't do any elective operations like hip replacements or knee replacements. I concentrate on the severely injured patient and operate on fractures of the upper limb, lower limb, pelvis, acetabulum, open fractures and closed fractures. I operate on children and adults, and I work at King's College Hospital in London, which is the designated major trauma centre for the southeast of London going out to the coast. And we treat about, or look after about a 5.3 million catchment population. And as you may or may not know, we're also kind of the designated trauma centre for a lot of the terrorist incidents that have been happening in London, unfortunately, in the last couple of months, last couple of years. In addition to that, I also work as a pre-hospital care consultant. So that's with the helicopter emergency medical service, air ambulance, etc. And I work in Essex and Herts because that's the county in which I live. I also have some academic roles, all of which are trauma related. So a lecturer at the Institute of Pre-Hospital Care and a lecturer at the Blizzard Institute of Trauma Sciences in London. I've completed medical legally. I've completed some bond solo courses in personal report writing, clinical negligence, and joint discussions with other experts. And I've been doing medical legal practice for approximately a year and a half now, coming up to 2 years. The claimant defense ratio, as you see there, approximately 80% for the claimant. So just to warn you now, there's lots of graphic images to follow, all taken with appropriate consent from the patients involved. So we'll look at 2 case studies. And in this first case study, just to highlight again, complex injuries and how they're managed. So we have a typical 29-year-old male driver involved in a road traffic accident, hit by a truck and then deflected into a tree. And that's typically the kind of scene that I would see as an air ambulance. And then this is typically what you're met with. And you obviously have a lot of police officers there, ambulance, paramedics, in addition to fire brigade. And you have to work with everyone appropriately and cohesively, get the patient out. Sometimes you have to cut the car apart to make that happen. And sometimes it takes a bit of time, but it's necessary to get the patient out safely. And then now with the benefit of pre-hospital care as a very evolved form of practice in the UK, we can do advanced treatment at the scene of the road accident. This is actually from a practice moulage, so that's actually a dummy that's going on, that's being managed, not an actual patient. And so we get everyone involved to help us, and we effectively take the A&E department to the patient at the roadside, take the ITU to the roadside, and we just start all the hospital treatments very early. Traditionally, the problem was that it would take a long time for a patient to end up inside a hospital after their accident. And even within London, with lots of hospitals and lots of big teaching hospitals, it still takes on average over an hour to get a patient from the scene of an accident inside an emergency department. So trying to do some of the emergency department treatments at the scene helps start that medical resuscitation and that medical treatment much earlier, giving the patient a better prognosis in terms of survival and morbidity. And then at the scene, the things that we can do include full-scale anesthesia. So that's a general anesthetic, intubating someone, so putting a tube into the top of their lungs and attaching them to a ventilator. We can also do surgery on their chest to either manage air in the wrong spaces in their chest, a pneumothorax. We can also do open heart surgery for the stab wound victims, start blood transfusions, and do some really advanced treatments that ordinarily would happen inside an emergency department. So in this case of our patient, his injuries included multiple rib fractures, a pneumothorax, and that's where you have air in the wrong place in the chest cavity. So air's not sitting in the lung, it's sitting outside of the lung, and actually it compresses the lung and affects breathing. He also had an open foot and ankle fracture with a very large wound. So he was brought into the hospital, and so the in-hospital treatment that he underwent followed national guidelines. And most of the national guidelines, of which there are plenty, but for this particular injury, involves surgical management for open fractures. So an open fracture is a fracture where there is an associated defect in the skin over that region. So a laceration, for instance. Sometimes it can actually be large, very large wounds, and sometimes very small wounds. The typical management strategy is to undertake initial temporizing surgery, where you clean the wound, so you debride the wound, you then wash it thoroughly, and then you apply effectively this Meccano set, also known as an external fixator, to help stabilize the bones and hold them in a nice straight line. That's a very temporary procedure in order to manage the infection risk there is at the start and to just stabilize the fracture. Typically, within a few days, we would aim to take the patient back to theatre and then do the definitive surgery. And that would involve basically taking the frame off and doing the necessary treatment you would need to have for your bone and the wound. And I'll come and we'll tell you what happened with this patient. So in this case, this patient had a large wound over the dorsum of their foot. So on the top of their foot had this large wound. All this black stuff is just clotted blood. And so he initially underwent a debridement, a washout, and then the Meccano set, as you saw in the previous slide. And then when you take him back to surgery, in typically about 3 days or so, ignore the car horn, it's just the NHS hospital and the car park outside. Then in that case, in the definitive surgery, you clean all this up again, and then you fix the bones definitively. So in this case, we've used plates and screws to stabilize everything. You take the external fixator off, and then you need to do some complex surgery to close this wound. Because clearly you can't just stitch the two ends of the skin together. You have to use something to close that. And this is where I work a lot with plastic surgeons very closely, and we do a lot of operations together for such patients. And in this case, the plastic surgeons will take some skin, fat, and fascia, and a little bit of muscle from the thigh of the patient. And so they make an incision over the thigh, harvest some of the muscle, and they take some of that tissue with its own blood vessel. So they'll take an artery and vein. So it'll be a lump of tissue. The skin's on the other side of it. It's underneath it. And this tube that you see here, tubular structure on the left, are arteries and veins that supply this area. You can then take this piece of tissue and then stitch it directly over onto that large wound. Obviously, you template it, so you measure out the correct size you need and the correct dimensions, so it fits really well. But it's effectively almost like a patch, but it's a patch of living tissue with its own blood vessels, and then you would plumb those blood vessels in to the main blood vessel in the lower leg. So you can see how it now sits there quite nicely, covers up the wound, and then the blood vessels are underneath the skin, and they're plumbed in to the main blood vessels in the lower leg. Because with such a large wound, if you were to take just a lump of tissue and stitch into the wound, hoping that it would heal, it wouldn't heal because it wouldn't get any nutrition from the blood vessels. So because it doesn't have its own blood supply. And so it would typically die off. That's why we always need to plumb in its own blood supply. So what happens with these patients with complex open fractures? So in terms of kind of how they recuperate, and now in terms of how it affects their recovery, their rehabilitation, and the medical legal aspects, well, a lot of these patients cannot wait there for a protracted period of time. Sometimes it's 6 weeks or 8 weeks, and occasionally they won't be allowed to put weight through their leg for even up to 3 months. That's done so we can allow the bones to heal and allow the function to slowly come back. They're typically off work for a prolonged period of time. A lot of these patients with this kind of injury, if they are office workers, they're usually off for a minimum of a kind of 2 to 3 months, maybe longer. If they're more manual laborers, it's typically even longer than that. It really does depend on the severity of the injury, but it's always longer than they initially think. I'm always very surprised, although I guess I shouldn't be, always very surprised when patients feel that with such a significant injury, they think that they'll only be off work for around 2 to 4 weeks. And then when I tell them, no, you'll probably be off for 2 to 4 months, it's a very different conversation. And obviously that has major implications for them and their finances, etc. A lot of them require care and assistance. As you can imagine, those people who have significant lower limb injuries in the legs, they have massive difficulties. And especially here in London, we have a lot of patients who live in apartments rather than houses. And so when you're living on the 10th floor of an apartment block, like I have now, I have a chap in the ward now who's in that state, then he needs significant care and assistance to help with that. And so that would involve a significant package of care that the hospital arranges. But again, that's something that may actually be ongoing for a long period of time while he undergoes his rehabilitation. There's obviously a loss of pay, especially for the self-employed. So we have, because of the major trauma center I work in, we have a lot of people who come in who have accidents at work for falling from heights, etc. And they have a loss of pay. Obviously, they have their normal pay for a period of time, but typically they're transferred onto their basic pay only almost immediately after their accident. So a lot of them have extra supplements to pay for the kind of dangerous work they do or the high risk work they do. They all lose that immediately after, and kind of always surprised to see them telling me about this when I see them in clinic. So a lot of significant issues for them. In kind of the mid to long term, open lower limb injuries are a really difficult one for people to return to work, especially if they have physical work. So we see, again, a lot of builders, roofers who sustain high energy injuries to the lower legs. And these are effectively career-ending injuries. So if they were a pro athlete, it would be a career-ending injury. If you're a manual laborer or a bricklayer, it's a career-ending injury. It's very difficult to get back up and about and be as active as you were and do the job you did after sustaining such a high energy injury. If you're an office worker, that's significantly different, and you may have an easier time getting back to work. But for those who are very active, it's very unfortunate. And it's very difficult for them as well, as you can imagine, because they would have to go under periods of retraining, etc. A lot of them have to buy a new car because they can't go back to their manual car anymore. They find it very difficult with their legs, or they may need to have a mobility assessment and then have an adapted car. A lot of them have long, ongoing limited mobility issues. A lot of the research that's been done, albeit it's very limited, highlights that there's rates of arthritis, which I'll come on to in a bit, but the rates of long-term symptoms, 50% advocates. So the vast majority of patients will have long-term effects from this. They'll have elements of superficial pain, maybe over the scar, and also deep pain associated with problems with the bone. In terms of timing of final prognosis, so this is obviously an interesting question in terms of when is the best time for the orthopedic surgeon to give the final prognosis. And typically for complex lower limb fractures, it would be a minimum of about a year to year and a half. So even the innocuous and the more subtle injuries take over 9 months to fully recover. So I generally, for most of mine, I would recommend a final prognosis at least a year to a year and a half down the line from the injury. And obviously you can do a report before that, but just in terms of that final opinion. There's a future risk of deterioration, right? So this is a common question again, is the risk of arthritis. So the studies that have been done in the medical literature are very poor at really outlining the real risk of this in the long term. Suffice to say, the vast majority of patients, so 50 to 70%, will have some form of arthritis on x-rays if you were to x-ray the relevant segment, be that the foot, the ankle, the knee, or the hip. How that radiographic arthritis correlates to clinical symptoms is it's not an easy relationship to kind of understand, because you'll have some patients who have really bad x-rays that show really severe arthritis, but functionally they're very well and their symptoms are manageable and they don't want anything further doing. And vice versa. You have patients who have really not much wrong on their radiographs, but actually they're very debilitated. So it's a case of making sure you really understand what their cause of their symptoms are. Is it arthritis? Is it something else? And then making sure you treat that effectively. And if it's arthritis, yes, there's a potential need for further treatment, and that could be reconstructive surgery with joint replacement or joint fusion. And so this is the case, as I just mentioned to you earlier. So just going on to case study 2, 40-year-old male, works as an accountant. He's playing his usual, Monday evening football matches. Obviously not really happening nowadays, but this was like a year ago. He was tackled while playing football, sustained this fracture to his tibia. So you can see there's a fracture there of the tibia, the main shin bone, and also the fibula, which is the skinny calf bone next to it. They usually fracture together. And basically he sustained the injury, came to hospital, and had ongoing severe pain in his right leg. He was admitted to hospital and he had worsening pain overnight. He was then diagnosed with compartment syndrome the next day. And so I'll just go on to what is compartment syndrome. Well, compartment syndrome is an absolute devastating condition where the pressure within a osteofacial compartment increases and stops the blood flow. And I'll just break that all down for you. So, as I say, what is it? Devastating condition where the intracompartmental pressure, so the pressure within an osteofacial compartment, rises to a level that decreases perfusion. So the question is, what is an osteofacial compartment? So this is a cross-section of the lower leg of any of us, really. So this is the tibia, the shin bone, the fibula, skinny calf bone, and all this pink stuff is different muscles in and around that region. Now, these muscles are all held very, very tightly by fascial tissue. And so fascial tissue is the typical kind of gristly kind of tissue that you would see, if in some of the pictures I showed you earlier. And that holds muscles in the right place and stops them moving in abnormal directions and holds the structure of the leg together. And so they are very tight compartments, and they're also effectively watertight. And within the compartment, you can see, within these compartments, you can see blood vessels that travel down and supply and provide nutrition for these muscles and bones. So what happens in compartment syndrome is you have a severe fracture. The fracture, again, can be open or closed. You get bleeding from the ends of the bone. The bleeding then effectively increases the pressure within that tight osteofacial compartment because that blood's got nowhere to go. As I said, that compartment is effectively watertight. It's surrounded by bone and this gristly tissue. That excess blood from the bleeding bone ends has got nowhere to go. And so as a result, you start to get increasing pain. So how do you treat it? So the only real treatment is surgical management. There are some exceptions to that rule, but on the whole, it's surgical management. And so if you look at these pictures here of the lower leg, of the forearm, these just outline roughly where we'd make our incisions. And the whole aim of the operation, and it's a fairly simple operation to be honest, is you basically cut the skin, the fat, and that gristly tissue, the fascia, in order to reduce the pressure and give the blood that's trapped in the compartment somewhere to ooze out. And that will automatically then reduce the pressure within that region. You obviously still need to fix the bone later, but the priority at this stage is to actually treat the compartment syndrome. And it's a devastating condition because it's very, very painful. And if it remains untreated, the pressure within the compartment increases to such an extent that it shuts down the blood flow in those blood vessels and effectively shuts off the blood supply to all the structures in that compartment. And those muscles all die off and the patient loses complete function in their lower leg, for example. So how do you manage it? As we've said, surgery is the main management. And you effectively, the operation is called a fasciotomy. And the otomy bit really means release of, and the fascia is the fascial tissue. So it's releasing the fascial tissue. When I describe it to patients, I describe it as like a low-level tunnel, and you've got a high buildup of pressure, and all you're trying to do is cut the roof off the tunnel and allow the pressure to come out, and effectively allow the excess blood to come out. There are national guidelines that provide guidance on how to diagnose and how to treat and when to treat these injuries. And the problem is surgery is that if surgery is deferred, with time, there's an increasing risk of tissue death, and i.e. muscle death. And sometimes if surgery is deferred, either because the patient comes very late to the hospital or for any other reason, then the risk of having a good outcome from surgery and from this condition is actually, it reduces significantly. There's an amputation risk in the long term for those people who have a delayed diagnosis or delayed treatment, and then chronic pain issues as well. And so this typically is how you do the operation. You have your lower leg, you mark out your incision, and then you just make an incision from the top to the bottom, releasing the fat, the skin, the fat, and the fascia. And then you get down to get down to muscle and then bone. This picture is a couple of days old after the initial surgery, so that's why it looks slightly different, but that's effectively the principle. How do you treat it? So eventually, over time, what you would then do after a few days after doing the operation is you take the patient back to theatre once every couple of days to ensure that if there's any dead or damaged or devitalized muscle, you can remove it to stop it becoming a focus of infection. And then eventually, once you're left just with healthy muscles, you would then eventually close the two edges of the skin. It's not always easy to close the two edges, and sometimes you have to do a skin graft. And so a skin graft is again where you take a bit of skin using a special machine called a dermatome. So you take a sliver of skin off somewhere else, like the other thigh or the back or the stomach, and then you stitch it on to cover up the hole that you had. And then eventually that heals down and they are left with significant scars. But hopefully, if caught early, they have a good outcome. Now, as I mentioned, even if these patients are diagnosed early, there's still a 20 to 30% risk of chronic long-term symptoms. That's usually pain, some element of weakness, and some element of functional disturbance. A lot of them, if treated very early, do have mobility that's restored to near normal levels, maybe occasionally with some limitations. But you get the spectrum of people who've been treated very early to very late, and those people in the middle who've been treated with a couple of hours delay or 10 hours delay, 12 hours delay, they will have significant limitations. But all of them will have a low risk of amputation. If you're diagnosed late, this is very different. You have a super high risk of long-term symptoms. Your mobility level is very, very poor, and you have a high risk of amputation. And even if you're very young, having an amputation can still mean that you have a very poor mobility level, just because it's very difficult to mobilize sometimes, even with appropriate prosthetics. Because a lot of these people who, in compartment syndrome, for instance, the lower leg, which is the most frequent location, they typically need a through knee or an above knee amputation. They can't have a below knee amputation. So they're functionally still very, very limited in the long term. And hand over to Chris, who's a pain expert. Obviously, Chris will tell you more about myself, but we work a lot in orthopedics as well with our pain teams, because as you've seen already, a lot of our patients, no matter how well they're treated, if they've been victims of major trauma, major injuries, still have long-term problems with ongoing pain. Thank you very much. Over to you, Chris.
Thank you very much, Ash. Right. Let's get this up. Excellent. So thank you very much once again for joining us, everybody. So I'm going to, my name's Chris Jenner, Dr. Chris Jenner. I'm a consultant in pain medicine, and I'm based at Imperial Healthcare NHS Trust. And I hang out at the top right hand there at Charing Cross Hospital in the pain clinic there. What we're going to do today is we're going to talk a little bit about pain, a bit about physiology of pain. We're going to spend bit more time on the anatomy of the pain report and what sort of information that you would see in there. And as Ash said, at the end, we'll do questions and we'll do a Q&A session at the end. So let's kick off with something simple. What is pain? Well, if we look at the definition of pain, we're looking at an unpleasant sensory and emotional experience which we primarily associate with tissue damage or describe in terms of tissue damage or both. Now, clearly that is a bit of a mouthful. So as pain doctors, pretty much we would say pain is whatever the patient says it is, because that's a lot more descriptive, and we'll come on to that. The time course of pain is acute pain, less than 3 months, and chronic pain, 3 months or greater. And there are 2 major types of pain. There's nociceptive pain, which is what we would call sort of normal pain, and that's sort of back pain, neck pain, arm pain, that sort of thing, arthritic pain. And there's another type of pain, which is neuropathic pain, which is essentially nerve pain, where there's damage or dysfunction to an element of the nervous system. The difference is with nociceptive pain, if you've got arthritic pain, people will say, you know, from Ash's patients, you know, they have these things happen. Their arthritic pain would be, you know, well, I've got an ache in my ankle, it's painful, I walk on it, you know, when I move it around, it's uncomfortable, and that sort of thing. Neuropathic pain, different ball game. This is where there's damage and dysfunction to the elements of the nervous system. So these patients won't be saying, oh, it's a bit of an ache. They use much more florid language. They'll be saying it's burning, sharp, lancinating, like someone's taken a blowtorch to it, like they're being stabbed, like someone's taken, you know, sandpaper to the area. And the types of injuries that Ash has been discussing, these complex orthopedic cases, when we get to see them both clinically and in the medico-legal setting, very, very often these claimants will have a mixture of nociceptive pain and neuropathic pain. So we need to pick through all the various symptoms of those with them. So let's look at some basic pain physiology. Well, if you go to all the lectures these days, about 90% of the lectures in pain conferences are all about pain physiology, and it's all about receptors and subtype receptors and subtype receptors and different neurons and neuroanatomy, and it all gets very, 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 very complicated. So in order to try and make it a little bit more palatable for everybody, let's see if we can get a slightly more entertaining version to work. So let's see if this all works. So first of all, we start off with a nociceptive input. So this is a pinprick. The pin current, which goes up in the spinal cord. There's about 5 different what we call tracts in the spinal cord, and ultimately these tracts end up in the brain. Now, the reason for telling you all of this is that pain is more than just pain. By the time that painful stimulus gets to the brain, it's telling you a lot of information. So if you cut your finger, your brain will tell you it's cut, where it's cut. There will initially be a reflex response to withdraw your finger from cutting bread or whatever it happens to be. There's also going to be an emotional response. Do I run away? Do I stay? Do I fight? What do I do? What are my memories of other types of pain that I've encountered, and how does that affect me emotionally? Do I burst out crying? How do I respond emotionally, etc.? So now you'll start to see neurophysiologically, it's not just the pain that comes in, it's all the allied issues associated with the pain. And we'll talk about that in a bit more detail when we go through the report. So in brief, if we look at the anatomy of a report in pain medicine, when I do these, I do the following. So summary of the case, very helpfully, you guys will send us a summary of the case, and we can take that out and use that as a sort of basis of what the case is all about. The pre-index accident medical records, I'll trawl through all of these, put them in chronological order if they aren't already, and basically summarize all of those. Pre-index accident, post-index accident, the same. Expert witness reports. In the claimant's cases, often there may not be much. There may be an orthopedic report, sometimes a psychiatry report. As the case progresses, obviously, then more and more other reports get added. Witness statements, if there are any at that stage, we'll put them in. Now, the history, what I do before I see any claimants is in advance, usually at least a couple of weeks before I see the claimants, we will send out pain questionnaires to them to be completed. And we can send you some examples of this, but essentially it's a detailed rundown of their pain: site, character, duration, radiation, aggravating associated factors, etc., what medication they're on for their pain, how it affects them psychologically, at work, employment, in the home, with their activities of daily living, etc., etc. So before I even see the patient, we have asked them a large number of questions, and we ask them to spend, suitable amount of time, usually at least 2 to 4 hours, going through it and just getting all that information down for us. Then the next thing in the report you're going to see is an examination. So when I see patients face to face now, we're very pleased to report that that's all back open for business now. I will do an examination. I'll start off with a general examination. So as you would imagine, that's things like their gait, posture, their affect, are they a normal affect, are they tearful, happy, unhappy, etc., etc. What was their journey like to the assessment? Are they wearing a sling? Have they got a walking stick or a wheelchair? That sort of thing. So all the general examination of the patient. I then would do a targeted examination. So we will have already picked up in the history section where the problems were. So for example, going back to Ash's patients, for example, somebody who's had a road traffic accident, and one of those cases where, for example, they've had a complex injury to the lower limb, as you would imagine, we would do a targeted examination of that lower limb, and we would compare it with the normal limb, if there is a normal limb in the case, but it would be a targeted examination. And that composes things like inspection, having a look, colour changes, hair changes, nail changes, swelling, any sort of abnormalities that you can see, palpation, that's going to be like touch sensation, pinprick sensation, basically a full neurological examination, including reflexes, power, etc., etc. And so we do a targeted examination of whatever area is involved. Also, at these assessments, I tend to ask further questions, and I've got a little crib with about 40 questions on it. Now, bearing in mind the claimants have already filled out a huge amount of paperwork, I still ask them extra questions about the accident, about their medication, about them psychologically, etc. And it is interesting because when they're free-flowing and chatting and talking, they often come up with extra information when they're not just sat there writing it. In the flow of conversation, they will tell you extra useful, often, information. And then ultimately, the thing that obviously you guys are interested in our reports is going to be the conclusion. So going back to the pre-index accident summary, what I'll do is I will divide this into pre-index accident pain-related entries, obviously in chronological order, psychological and psychiatric entries, and then other health issues. And obviously this can have quite a significant bearing on the number of cases. We see anything from patients who have 0 pre-index accident information to patients who have sort of anywhere between 150 and 300 entries in their medical records, including multiple pain issues, multiple psychological and psychiatric issues. And so obviously in those cases, we have to look very much more carefully at the Preindex accident issues and how those will influence that patient's presentation with pain afterwards. We do a summary of the accident itself. So the sources of information there are the instruction from your good selves, the contemporaneous records, A&E records, or any other records that we find. And again, I always ask the claimant themselves, and again, they come up with some useful information there. And then we look at the post-index accident summary. So what's very useful here to know about is what happened in the immediate aftermath of the accident. After the accident, did you do anything from get back in your car and, you know, swap details, get back in your car and drive off, to the other extreme of you're unconscious and cut out of the vehicle by the fire brigade, and as I saw a claimant yesterday, woke up in an intensive care unit 2 weeks later with extensive injuries to the lower limbs that had been fixed by the surgeons. So it is important to know exactly what happened afterwards. In more simple cases, it may be when did you first present to your GP, or when did you first present to casualty or another healthcare professional. And then really we want to know about the evolution specifically of the pain and any other symptoms after the accident. Reliability and veracity, obviously this is very important, and we do look for obvious inconsistencies. To flag up one recent one is a claimant that was claiming pain on their right lower limb to one group of experts, and to their left on the left limb to another group of experts. And as you can imagine, there was some somewhat fishy things going on there. So you need to just keep an eye on those little details. Then we look at things like unconscious exaggeration, and of course potentially conscious exaggeration, for which really we're looking at surveillance, which we'll talk about later. Just to put this up, the fear avoidance model of pain. This is useful in a medical legal setting. In the middle here, you have an injury. Patients experience pain, and what's supposed to happen is the right-hand side. They have no fear, they confront it, and they recover. So they have an accident, they have some pain. It's not great, but it gets better, and they get better, and they get on with their lives. What happens in a lot of these claims that we see is they will have an injury, they experience pain, they may catastrophize about the pain. So that's essentially thinking about it, ruminating about the pain, and discussing it with friends and family, and being preoccupied by it. Then becoming fearful of movement, because in their own minds it may cause re-injury and more pain. Becoming hypervigilant of the injured area. Then they may start to disuse the area and become increasingly disabled. And of course, all those physical issues will start to have knock-on effects with them psychologically, causing depression, anxiety. And all of those things, as we know, will feed back into the experience of pain and amplify it. And then these patients will go round and around in this vicious cycle of pain. So what we do need to do in our pain report is we do need to tease out the different types of pain that the claimant has. So as we talked about at the beginning, we have nociceptive pain. So that's essentially where the nerve signaling pathways are intact. Neuropathic pain, as we said, where the nerve pathways are dysfunctional. As we said, with Ash's cases, particularly in complex orthopedic trauma cases, it's very, very common to have mixed nociceptive and neuropathic pain. So again, going back to Ash's cases, you will have patients with those types of injuries. By the time they get to see someone like myself, a pain specialist, they may have pain from the initial injury, pain from the surgery, such as the fasciotomy, pain from the plastic surgery and the skin grafts that they've undergone, pain from the skin graft donor sites, pain from the donor sites from the muscle and connective tissue, as he showed us. They may have neuropathic pain added into that. And if that wasn't bad enough on top of that, as Ash mentioned, they may well go on to develop arthritic pain, and particularly that is a problem where there's some sort of disruption to the articular surfaces, that's the joint surfaces themselves. And as he mentioned, there is a very high incidence of arthritis in those types of post-traumatic injuries. Sometimes at the bottom we use the ICD, which is the International Classification for Disease, which is basically a menu of different titles, as it were, for different types of pain. And the range of opinion, well, we have to think about this. Initially, most pain patients, there will be some sort of biological or organic cause for their pain. Equally, in some patients, there may be a psychological or psychiatric cause, or at least contributing cause, and that is things like mood disorder, PTSD, post-traumatic stress disorder, adjustment disorder, and increasingly we see SSD, or somatic symptom disorder, which we're going to chat about a little bit. And then we have to consider non-biological and non-psychological causes. So essentially there we're looking at conscious and unconscious exaggeration of symptoms. Now I'm just going to put this up. Obviously I'm a pain doctor, I am not a psychologist. However, there does seem to be quite an overlap with this particular condition and pain. So I thought it'd be helpful just to run through some of the basics. So SSD is somatic symptom disorder. Somatization is psychological or emotional distress, which is manifest in physical symptoms that are otherwise medically unexplained. 5 to 7% of the population, 10 to 1 females to males. And it's really a heightened awareness of certain bodily sensations and a tendency to interpret these as indicative of medical illness. Risk factors: childhood neglect, sexual abuse, chaotic lifestyle, alcohol, substance abuse, personality disorders. I would say when going back to the pre-index accident medical records, certainly where we have patients who have extensive pain, psychological, psychiatric and other healthcare issues, these often get picked up by the psychiatrists that there is an element of somatizing, because way before these patients, claimants, have their accidents, they probably had a history in their medical records of going to and from their GP, to and from the hospital with various complaints, various bodily complaints. And, you know, as a sort of example, you would see a kind of a litany in some of the patient's records of headaches, back pain, arm pain, tiredness, fatigue, just sort of general vague symptoms that come and go, that basic blood tests and basic tests don't really find any basis for, but they are relatively frequent attenders. So the next thing to talk about is the psychosocial model of pain. And I mean, in simple terms, this is saying that when we consider pain in a patient, in a claimant, we don't just look at the biological aspect of the pain. That is one aspect. We need to look at the biological aspect in association with the psychological aspect of their pain, in association with the social aspects of their pain. So when I'm going through when I do the conclusion, post-index accident biological factors, well, let's talk about some of Ash's patients. Well, they may have nociceptive pain. So they've got pain from their operations, they've got pain from the scars, they've got nociceptive pain, they've got some neuropathic pain, they've probably got some arthritic pain, so they have plenty of actual biological factors giving them pain. Psychological factors, so they're probably depressed, they're probably anxious, they may be having relationship difficulties at work if they're at work, social difficulties at home, difficulties with their kids, can't play with the kids, arguing with spouse, working less or not working at all, or having employment difficulties. Maybe they can't drive, or their driving is restricted, or their activities are restricted. You know, the list goes on. But then we look at a person who has pain. Initially, pain is their primary presentation to me. But then when you start to factor in their psychological issues, and then we start to factor in their social issues, then we start to see a much larger picture of how this pain is affecting them globally, as it were. When we come to causation, as a pain expert, generally we're not the primary expert in the case in terms of causation. And certainly with Ash's cases, we would be saying, number one, causation, I defer to the expert witness in orthopedic surgery. The orthopedic surgery will hopefully be saying, yes, Mr. So-and-so was involved in the index accident, sustained complex injuries to the lower limbs, and as a result has the following. Likewise, for psychological and psychiatric issues, I would defer to the expert witness in psychiatry, and they often give us a lot of extra useful information. Likewise, in neurology, if there's any serious, significant neurological deficits, often these patients are assessed by a neurologist. So if there are other experts that can give us concrete information about causation, then yes, we will put that in there. And then we'll say, on the balance of probabilities from a pain medicine's perspective, Mr. Bloggs was involved in the index accident and has the resulting pain as a result of the index accident. And it all fits nicely together. That's the most important thing. Obviously, if the claimant has pre-existing issues, it may not be a direct causation, it may be an exacerbation, in which case we may be asking the orthopedic surgeons how long is the exacerbation for, or we may be liaising with them as to that, or it may have been a finite exacerbation for a certain number of months or years. It just depends on the case. In our prognosis, as you can imagine, by the time these claimants see myself as a pain doctor, it's usually several years down the line. So we can say, well, it is now X many years, Y many months have lapsed since the index accident. And pretty much, on the balance of probabilities, the claimant's pain is unlikely to spontaneously resolve. What does that mean? What that means is the claimant's had an accident. Once you get past 3 months, as we said at the very beginning, that pain is now classified as chronic pain. I'm now seeing them at 5 years and they're saying, doctor, I have pain. That pain's probably been with them pretty much since around the time of the index accident events. It's not going to disappear. Once it's got past 3 months and it becomes a chronic pain problem, unless they have other treatment, the likelihood, as we say, that they will wake up one morning and all that pain has miraculously disappeared is unlikely. It's virtually negligible. So if you see that patient at 4 or 5 years after an accident with persistent pain, if you don't do anything, that patient will basically go on to have that pain indefinitely. And so we have our last bit of the prognosis summary, which is On the balance of probabilities, the claimant's pain will continue indefinitely and can therefore be considered permanent. So we're just going to talk a little bit about treatment. So one of the other things that we put in our conclusion sections about treatment, and generally speaking, the sorts of claimants that we see will need a multidisciplinary team approach. So that's using obviously different healthcare professionals. Pharmacological treatments, this is usually headed by the pain specialist, and this is things like anti-nerve pain medications, ones that people are familiar with: pregabalin, gabapentin, duloxetine, multimodal analgesia, so you may use anti-inflammatories, paracetamol, weak opioids, tramadol, codeine, oxycodone, those sorts of things. And you may use multiple different medications which have different mechanisms of action, which when you put them all together as it were a cocktail, you get the most benefit, so most efficacy, with hopefully minimal adverse effects. And the overall aim of these pharmacological agents is to try and break the cycle of pain, reduce the patient's pain, to allow rehabilitation, which we're going to come on to. That's just the WHO's pain relief ladder. Psychological treatments, these days a lot more patients are getting these. Clinical pain psychologists, counselling, CBT, EMDR, RTMS, there's all sorts of other types of psychological treatment available, and that's more to deal with things like the PTSD, with the mood disturbance, with the adjustment disorder, etc. A lot of patients end up with minimally invasive pain management procedures. So essentially, a lot of these are image-guided injections, usually using steroids, long-acting local anesthetics, Botox, that sort of thing. We often use C-arm X-ray. This is a patient having some spine injections with steroid done for them. We also use radiofrequency treatments, which we can talk about later if you want to, but basically we can treat nerves with pulsed radiofrequency, and we can destroy nerves with radiofrequency denervation. So we can actually make nerves work properly in some types of neuropathic pain with a non-destructive treatment. With a destructive for very, very small nerves that aren't doing much else, we can treat certain types of spinal pain. We also use a lot of Botox. Very, very, very versatile drug is Botox, and we use it for spasticity. We use it for neuropathic pain. It can be very, very helpful. Just to mention, there are advanced types of pain management. The one that most people know of is spinal cord stimulation, and essentially what this is a very expensive implantable TENS machine. So you'll have electrodes, as you can see in the diagram, lying over the spinal cord. The electrodes go back to a little IPG, which gives an electrical current, and usually the patient will have a handheld remote control to change the configuration of the electrical current that they receive. And it's like a counter stimulation type thing. It is like a TENS machine, really. But it costs about between £30,000 and £50,000. We can talk about that later if you wish as well. Now, physical treatments, this is probably more useful to talk about. As we said before, we do have lots and lots of different treatments for patients, but from my point of view, at the end of the day, all of the treatments that we offer, in my opinion, excuse me, the main aim is to get your patient, to get your claimant to the physical therapist, the physios, the physiotherapists. We often work with specialist pain physiotherapists. They do things like graded exercise programs, strength and flexibility training, cross training, and they're really looking at functional improvement. So, for example, with Ash's patients, physiotherapy will be absolutely vital. They've had the injury, they've had the initial surgery, they're starting to recover. We come in and try and sort their pain out. Then rehabilitation, getting them back walking, rehabilitating them, getting their balance back, trying to get them not dependent on walking aids, etc., etc., etc. That is the key thing. And then, of course, the step from there will be one of the things we're always interested in, which is a return to the workplace, which we'll talk about. We also go through a long list of current activities of daily living, including home life, and quite some detail on current employment. We look at pre-accident employment, but employment. And future employments, in the conclusion, I mean, basically one of the big treatment options, believe it or not, that we have available is actually getting patients back to the workplace. And as it says there, it has psychological benefits, physical benefits, social benefits, financial benefits. So taking that patient, rehabilitating them, and then reintroducing them into the workplace in some sort of as some sort of entity is a very, very, very important endpoint. And always, despite whatever injuries people have sustained, whatever situation that they're in, we always try and return them to some sort of work, even if it's not what they did before, even if it's more sedentary, even if it's in a part-time capacity, because of all the benefits as listed there. Future care requirements, again, a bit like the employment, we do not want to have patients who are just fully dependent on care. One of the aims of treatment is to minimize their care. It's to make them as independent as possible, so they don't need too many aids, they don't need as much assistance, they don't need somebody coming around helping them every day, because by making them more independent, it helps them socially, it helps them psychologically, it helps them cope with the whole thing. Yes, of course, in some cases, patients may require help with DIY, with gardening, that sort of thing. And yes, of course, when patients have very significant injuries where care is required, where they need, for example, a wheelchair because that's what is required, then they may need you know, ground floor accommodation, they may need ramps for wheelchairs, they may need grab rails, etc., etc. That's a different ball game. Then obviously in those much more intensive type cases, an expert witnessing care will almost certainly be found and do a report. Surveillance, well, I'm sure like all of you, we could all regale each other with stories of surveillance, and we could in fact spend the whole afternoon just talking about surveillance. Obviously we've all seen some real corkers of surveillance where the case has essentially collapsed as a result of patients telling you one thing and doing something entirely different. But I would say the vast majority of the surveillance that I see, particularly for claimants, is fairly sedentary, fairly pedestrian, people walking around, doing light activities, you know, going to the shops, mooching around, driving a car, going to medical appointments. It's very rare to see a real smoking gun, but obviously when you do see that smoking gun, it can be quite amusing. So we've come to the end of excuse me, my parts. So any questions now? Excuse me, I think I'll just get some water. I'll just stop this screen share. Stop share. All right, I'm just going to get some water.
Hi, so yeah, welcome back, guys. Thanks very much, Chris. So just a question for me that's just come up. So the question is, what are the options of managing arthritis in both the lower limb and the upper limb? Well, the options generally are of arthritis there's a spectrum of options from non-operative to operative. So the non-operative options are splints, supports, and physiotherapy. I think that's a basic for everyone. Everyone that we see clinically will always go through the non-operative options first, of physiotherapy, splints, and other supports. Then you go to any kind of intervention. So you could have injections, so that's steroid and local anesthetic injections into a joint. They typically are very much around symptom control. They don't cure anything. There are some people who advocate the use of specialist injections that effectively is designed to improve the mobility and function of a joint. But again, research has shown that, you know, their usefulness is somewhat questionable. But the main one is steroid injections. And then beyond that, surgical techniques are either fusion or replacement. By and large, that's what they are. In the lower limb, we predominantly replace the hip and replace the knee. You can fuse it, but the functional outcome, again, is very limited. So we tend to do replacements. And hip replacement, knee replacement, generally, you know, well-tolerated operations with good prognosis and good results and good outcomes. In the foot and ankle, it's largely fusion, though. There is some ankle replacements that we do, but by and large, it tends to be fusion, especially for the younger people who kind of more, you know, intensive demand. For the upper limb, again, it's replacement for the elbow and the shoulder, so you can keep the mobility. And it's fusions predominantly down in the hand and fingers. Occasionally, there's replacement options. And then in turn, there's a follow-on from that. Is there any difference between the two? Well, obviously just gone through that. And then does arthritis happen in children as often? So interestingly, the younger the child, the less risk of developing degenerative symptoms, i.e. arthritis-related symptoms. But that's still all there, even in the child. It's just less frequent. I think there's a couple for you, Chris, that I'm looking at on the ones that have been pinged to us as well directly.
Yes, thank you. So, I mean, Ash has basically covered everything there. The only things I would say is in terms of pain management techniques for particularly the arthritis, certainly all those medications that we mentioned, there's all sorts of things that we can do there. Certainly if people have sort of low-level constant arthritis, occasionally things like buprenorphine patches can be useful, and other medications. Obviously, the thing about medication which we didn't talk about is that you know, with all the medications you have potential adverse effects. We go through those with the patients, and you've got the potential benefits versus risks of them, really. So you have to balance those out. The only other thing, Ash mentioned that with a lot of arthritic joints, yes, you can inject steroid. We do quite a lot of something called viscosupplement as well, which is like a jelly-like substance which is put into the joint, which some patients respond to extremely well. And there are other techniques that people are looking at, things like PRP, platelet-rich plasma injections, and that sort of thing. So there's a range of different treatment options, anything from simple analgesic medications all the way up through injections, all the way up to full-on joint replacements. And then again, the physical rehabilitation is very, very important.
There's one that's come. So the question is, infection can be, I'm reading this on the chat box, but, so infection can be one of the main reasons why amputation is required, sometimes many years post-accident. How do you assess the future risks or chances of amputation in a claimant who is presented with infection? So that's a really interesting question. So, I do see a fair amount of infection after accidents. So there's probably two groups I think about. So there are the people who present significantly after an accident. So we're talking 5 years, 10 years, even longer potentially. And they're typically the ones who had an accident a long time ago that kind of wasn't really well managed. Mainly just, and I wouldn't say, no, sorry, so not well managed compared to current practice, shall we say, but probably appropriate practice for the time and appropriate practice, the geography, especially if they came from if they had come from another country where the accident happened. And so, yeah, so they may have some infection from an open fracture that kind of was never really managed fully, and it's just been indolent, and then it kind of flares up. So that's one kettle of fish. However, I would say that generally these days, the techniques and management strategies are really, we're doing very well overall in the UK compared to pretty much everyone else in the world in terms of managing the trauma patients, which is significantly different to how it was 10 years ago. And so now what happens is everyone who has kind of any open fracture, they get this, senior input from a consultant orthopedic surgeon, consultant plastic surgeon at the same time. There's lots of joint operations, which is why I work closely with plastic surgeons to try and mitigate against any long-term risks of infection. Even saying all that, if someone does have an infection, we tend to pick it up early, and we tend to aggressively manage it and try and treat it effectively, surgically debride it, and effectively try and cure it, so it doesn't cause the patient long-term problems later down the line. And so we don't really have that many patients over the last 10 years, say, of practice that I've got who had an injury 2 or 3 years ago and they're now coming back infection. Most of them have been managed effectively at the time or a few months after, whenever it was found out. So I don't think it's a huge problem anymore. There is definitely a long-term infection risk for open fractures, but again, we look at various things. So in my reports, I look at kind of the area in which the open fracture happened. Did it happen in kind of a dirty environment? So marine, agricultural, sewage, and anything like that. Yeah, you'd be surprised about the sewage works. And then that's almost asking for a certain type of operation, unfortunately. And then so you have those kind of things. And then looking at the size of the wound, and then you're looking at factors about the patient themselves. So very young, very fit, healthy patient without any medical problems, like without diabetes or blood pressure or vascular problems, they have much more resilience than, kind of a very old patient who has very poor circulation, has really, really severe diabetes. So you look at the patient and the environment in which the fracture happened.
Fantastic. I've got one last quick question here, which is, can pain caused by the injury become a learnt behaviour / fear, making the patient think, if I do this action, I will get pain, even when the accident damaged tissues have healed? This is all about sort of maladaptive behaviours and maladaptive thought processes. And in those sorts of cases, the accidents happened, all the soft tissue injuries are healed, all the fractures have healed, all the soft tissues healed. There's no orthopedic cause for the ongoing pain. So basically we're left with, right, the orthopods can't find a cause for it. The patient complains of ongoing pain. We have to look at that very, very carefully. And often in these cases, we may ask the psychiatrist, if they haven't already seen them, to review them. And you often find, again, going back to that psychosocial model of pain, that biological aspect of their pain may be relatively small, but it's amplified hugely by other factors, particularly psychological factors. So yes, they can definitely have maladaptive thoughts and behaviors about that. Okay,
I think that's pretty much it, really. So we'll wrap it up here. Thank you again, everyone, for kind of tuning in, spending a bit of your afternoon with us. Hopefully you found this informative and useful. If there are any questions, obviously feel free to email our staff at MLP, and kind of we'll aim to get back to you and answer any other questions you think of later. But aside from that, thank you very much, Chris, for your time.
Thank you, Ash, and thank you everybody for your attention.